And so good afternoon and welcome everyone. My name is Amy, I use she, her, and I'm happy to have you join us today as we get into a great session. Before we dive in, there's a few things I want to cover. First, I'd like to acknowledge that while I'm joining you virtually, I am coming from the traditional land of the Huron-Wendat, the Seneca, the Haudenosaunee, and most recently, the Mississauga of the Credit River, and that this land is covered by Treaty 13. And I'm very excited to be welcoming today our two great representatives from the Scarborough Health Network. We have Sangeetha Navaramanathan, and she is a first-generation Tamil woman who has worked in healthcare since 2017. She has held various positions within the healthcare institution, including Sinai Health Systems, Toronto Central Local Health Integration Network, University Health Network, Southlake Regional Health Centre, and most recently, the Scarborough Health Network. Sangeetha is a registered teacher and social worker in the province of Ontario and holds degrees in education, work, and equality studies. At the moment, she is pursuing her certification as a Canadian Certified Inclusion Professional through the Centennial College and Canadian Centre for Diversity and Inclusion. We also have Jan Hastings-Winning, and she is an educator and author of textbooks. And in Jan's words, I'm a widow and have been involved at the PFA for almost 6 years. Following the death of my husband, I am now a co-chair on the PFA committee and sit on a few committees as well, including the Scarborough, Ontario Health Team and committees related to that. As well, I sit on many other short and long-term committees over the years. And so we're really lucky to have both of these very well-experienced and well-spoken ladies joining us today. And I'm very happy that we can all join today on Zoom. And with that, I'm very happy to now hand things over to our speakers.
Hello, everyone. Hi, I'm Sangeetha, and it's lovely to be able to join all of you today. I want to say thank you to Amy for inviting us to do this session with all of you. I just want to make sure that everyone can see my screen, yes or no. Yeah, I've got a few head nods. Okay, so good. All right. So today, Jan and I are going to be talking with all of you about advocacy for caregivers. So I'm just going to jump right in. Maybe if the slides are going to go. There we go. So we have a packed agenda for you. So we're going to start with a few introductions. I know Amy already did our bios, but we also wanted to just sort of say hello as well. And then I'm going to talk a little bit about the Scarborough Health Network. I'm also going to talk a little bit about Scarborough itself and sort of the unique patients and communities that we serve. And Jan is also going to share some of her story about what brings her to the Patient and Family Advisory Council. We're going to talk about patient and family advisors at Southlake, and then we're going to get into how to advocate and resources, and then we're going to have a few question and answer sessions as well. So here we are. I'm Sangeetha, so that's my picture, and then that's Jan. Yes, Jan, do you want to say hello?
Hello, yes, and just my name is Hastings-Winner. Just it was not correctly pronounced at the beginning, right? So, and you'll learn a bit more about me as we go along.
So, also, so we can get to know some of you. If you feel comfortable, feel free to put your name in the chat box and maybe just a little blurb about what brings you here today. We're hoping to have lots of time at the end of the discussion for questions. Obviously, if you're not comfortable, feel free to leave it. We can, chat later at the end. So whatever you feel comfortable with, okay? So, a little bit about the Scarborough Health Network. So I like to start with this slide mainly because it can be confusing. I know the Scarborough Health Network had names previously like the Scarborough Hospital, and it's more than one hospital, but it's 3 sites. So just to kind of give you some context, the Scarborough Hospital is one hospital made up of 3 sites. And the sites are the General, the Centenary, and Birchmount Hospital. So all 3 of those sites are major community hospitals with teaching affiliations to the University of Toronto. The hospital has many clinical programs, including post-acute care, palliative care, mental health services, diagnostic services, ambulatory care clinics, the emergency department, critical care, obstetrics and pediatrics, there's general medicine, surgical services, so like everything basically. The hospital also has 2 regional programs. So there's a cardiac program and there's also a nephrology program. And incidentally, the nephrology program is actually, from what I understand, North America's largest. So a pretty large hospital with a lot going on. Yes. And so a little bit about Scarborough. So Scarborough is home to over 600,000 people, and it is also one of the most diverse and at-risk communities in Canada. So residents of Scarborough include vulnerable populations such as visible minorities, foreign-born, children living in low-income families. So go to our next slide. So we talked about some of these stats. So in addition to some of the things that I mentioned previously, about 17% of households are headed by lone female parents. Almost 10% of the population is unemployed, 20% having no high school education. So there's a lot going on with the community, and I'll come back to these slides a little bit later in my presentation as we talk to sort of the patient experience and patient and family advisors and the patient perspective. But I just wanted to lay the foundation here at the beginning. But that is not the only thing we want to focus about when we think about Scarborough. So we also want to think about some of the strengths and some of the resiliency that we see in our communities. And I am going to let Jan speak to some of the.
I mean, if you're a Scarberian, then you well know these things without having to be told, right? But I mean, obviously things like food is one of the very strong pluses of Scarborough. There's very little you can't get in Scarborough, whatever your taste preferences are, or if you want to try something new, right? It's culturally one of the, if not the most diverse parts of Canada, which I think makes it a big an asset for the community. And of course, there's also the things like the beach and the bluffs and all those other kind of cool things as well. And one of the things when I talk about culture is music, right? And the kind of like big stars that come out of Scarborough who tend to get ignored and swept into, we're from Toronto, not from Scarborough. But anyway, there is all of that, and authors as well. There's a new film played at TIFF called Scarborough and things like that. Anyway, you all, I'm sure, know many of those things, but Scarborough is a sort of a sum of its parts, and it's got lots of good things as well. Okay, that's me already. Okay. So that picture is not anybody. I only know one of those people in that picture, and she no longer works for SHN. But anyway, I will start. So I was married over 30 years, and there is a bit of a difference in age between my husband and I. So he was definitely older than I was. And we were blissfully going along, and he had actually broken his ankle, and we lived in a house in Toronto, and we had a 2-story, 1-bathroom house, and I could see into the future, and it needed to be a bungalow. So we moved to Scarborough, and that was a brilliant decision because we could get a bungalow in Scarborough and afford it. Things were going merrily along, and then he started having these falls, and we went off to the hospital. And the first time he went in the hospital, altogether was 4 times. It was a week. And this was, I didn't know anything about supporting a family member in the hospital. I just figured you went in and they came out. My sum total of being in the hospital, I think, was my tonsils when I was like 4, right? I went in and I came out. And as far as I know, and my brother actually was with me. So, you know, like that was my sum total of being in a hospital. Well, actually I had pneumonia, but really I was a child and I had no understanding of being in a hospital and what you were supposed to do. And then on one particular day, my husband, a PSW needed to be called, and I buzzed the little thing and no answer, little thing and no answer. So then I went to the front desk and you could hear that the PSW was being paged and no answer was happening. And there was definitely something very much amiss in this story. And when the PSW finally appeared, the comments that she made outside the hall were highly inappropriate. I'll leave it at that. But I went back to that front desk person. I don't know what their title is, probably manager. And I got a card from him saying that if I wanted to pursue my concern, I could call the person. It was the patient relations director or whatever her title was. I said, okay. I was only there for a week. And I think for many people, well, he was only there for a week, but I felt like I lived there too. You don't want to kind of like get people upset with you. So I decided to do nothing, and he was discharged and it was fine. And this whole story takes to the end when he passes away. The next time he goes into the hospital, he's in for about 9 weeks. And this one is much more serious. And I have a day job, and I have, like a few things to do in between. And so I ended up having to go to Ottawa for a couple of days. And I have benefits, so we're paying for semi-private. And that's when they decide to move him into a ward when I'm not there to deal with it. So luckily I had that little card. I have no idea why I had it with me. That makes no sense to how I had it. Maybe I Googled it, I don't know. Anyway, I got Teresa, her name was, and I had a conversation not only about what was going on there, but also about what had happened previously and what would have been going on in the meantime, and had a little conversation. He was moved back to a semi-private, and by the time I got back. And this was where I was sort of beginning to realize that you actually have to advocate. You can't just assume things work well. Like, for example, food. You fill out a little menu choice and you think what you put on it, but no, that doesn't always happen. So sometimes, and in fact, frequently, I don't even know why, they would send yogurt. He hates yogurt. He hates yogurt. And that's such a waste of resources because he's not going to eat it, right? And so these are where I had to like really become like, you had to stand up and say like finding who is going to fix these problems. And I had no idea how complicated it would be. The third time my husband went into the hospital was for 17 weeks. And when he went in, it was February, Valentine's Day, in fact. And in the morning, he was normal, fine. Everything was nothing was wrong. And I had gone to a workshop. I'm a teacher. I was a teacher. And I came home in the early evening, whatever it was, 5 o'clock or something like that. And he did not know who I was. He called me some strange name. And it was so like, I've never seen this before. So I called 911 for the 5 millionth time. And they wouldn't let me off the phone. It was very strange, actually, like from my perspective. And they came, they took him into the hospital. One thing I've learned about that is you should not go with the ambulance because then you can't get home. So I followed along, and in that particular night, they asked me 4 times about end of life choices. Once is fair, twice did I mean it, but 4 times means someone's not paying attention. He had pneumonia, a very virulent kind of pneumonia. I have no idea how he could possibly have gotten it. So I had to gown up and mask up, which today seems normal, but at that time it was not. He was in isolation, and only I could go in to see him. And he started to get better. He did not pass. He fought off pneumonia, which was a miracle, and he was getting better. And he was up and slowly moving because he'd been in the hospital in the bed for quite a while. And they moved him over to Margaret Birch, and we'd been over there before. This is all at Centenary. And somewhere in this process, he was having so much pain that you couldn't even touch him. And the pain, like, and he's not a complainer. Like, he would never complain about pain. So the fact that he was in that much pain, you knew it was serious. And it took such a long, I had to keep advocating for getting someone to find out. They just kept giving him pain medication, which wasn't even working anyway. So in the end, they did a few things. We actually went over to Mount Sinai for a test somewhere in that process. And then they did an MRI. And he's very afraid of enclosed spaces. I forget what the word is for that. So, and I have had many MRIs myself. I'm related to the story. So I knew this was going to be very difficult. I said, why don't you just like give him some kind of relaxation medication so you could give him the MRI? Did they listen? No. So when they got him down there, they couldn't keep him in because claustrophobic is the word, because he's so claustrophobic, they could not do the MRI. So then I ended up, we did it another day or two later. I had to take a day off work. I had to go in with him. If you ever had one, they're very noisy. I did have like earphones and try to pull him and keep him calm. And again, they still didn't give him any medication. But because they rushed it, they had to do it a third time. But this is where, as an advocate, you need to always be advocating for your loved one because they don't know them as well as you do, right? In the end, he was discharged after 17 weeks. He came home. He was paralyzed. I had to organize ceiling lift, wheelchair, ramp, hospital bed, PSW support, all those kinds of things. And you have to kind of navigate that whole, the interdisciplinary team that is now coming to your house. I had to deal with the social worker at the hospital in terms of whether he was coming home or into care. And that was a very traumatic experience as well, which I won't get into right now. He was home for about a month, I guess I'll say. I couldn't wake him up one morning. I had just signed the last piece of paper on Wednesday that everything was fine. Friday, I couldn't wake him up. We went to ICU and made the decision not to do extraordinary measures. And he moved from ICU into acute care, and he passed away that night. As a result, I volunteered to be a patient family advisor to try to help make things better for other people. Things have improved significantly, I'm well aware, not just because of me, other people as well, because the voices of patients and families are part of Scarborough Health, and so they are trying to make things better, not just food and those kinds of things. That's it.
So kind of zooming out a little bit, I mean, listening to Jan's story, it's hard. It's hard to hear what patients and their loved ones are going through. And the reason why we've got patient and family advisors is because as a health system, we need to hear this feedback, right? Like it's so important that we know what's happening from that patient and loved one perspective. So, when we think about the patient experience, I think part of that is defining what are we talking about when we talk about the patient experience, because it might help in understanding just, again, why we work with patient and family advisors, why it is important to have places where people can advocate. So the definition that I use for patient experience, and that a lot of folks use, is taken from the Barrel Institute. which is a global community of over 55,000 healthcare professionals and experienced champions committed to transforming the human experience in healthcare. And so they believe human experience is grounded in the experiences of patients and families, members of the healthcare workforce, and the communities they serve. So the way in which they define the patient experience is the sum of all interactions shaped by an organization's culture that influence patient perceptions across the continuum of care. So I'm just going to say that again because it's a bit of a mouthful. But the sum of all interactions shaped by an organization's culture that influence patient perception across the continuum of care. So the reason why it's so important for us to have patient and family advisors is because we can't always see things from the patient's perspective, and we need to ask patients and their loved ones for information on how they are perceiving things within the healthcare system so that we can ideally make things better. So a patient and family advisor is someone who has experience with the healthcare system, who can provide a unique perspective and valuable feedback on the standard of care that they receive. So who makes up our patient and family advisory group? So it's any patients that we have, current or former. There's some parameters around if you're a current patient. There's also loved ones. And I always say loved ones, even though we call them family advisors, we all know that there's different ways in which people define family, right? So it's anyone essentially that cares about the patient and that's involved in their care. And then there's also caregivers, and sometimes that's a more formalized role in a healthcare setting. But those are the folks that make up our patient and family advisors. And I've talked a little bit about why we have them. By partnering with staff and contributing their insights, they provide direct input into policies, programs, and practices that affect patient care and services. So what does that look like? So one example is like Jan today sharing their personal healthcare stories. A lot of our patient and family advisors use their personal experiences to help us understand what the healthcare system looks like from a patient perspective. They represent a broad range of patients' interests, needs, and backgrounds. So thinking about some of our first slides that we presented, where we talked about the diversity of Scarborough and sort of all the different folks that live and work in this community. It's really important that our patient and family advisors do represent that diverse background because one person cannot sort of give us all these different perspectives. And so that's something that we're really proud of, I think, at the Scarborough Health Network as well, is that our patient and family advisors, we try to make sure that they represent a diverse group of folks. Our patient and family advisors also advise us on how we can work with patients to design, plan, and improve healthcare services. We strive to listen to opinions, listen to their experiences and their suggestions, and they help us frame and focus discussions and topics and meeting objectives. And ideally, between our patient and family advisors and staff, we engage in constructive and respectful dialogue and feedback. And so, Jan, I don't know if you want to talk a little bit about some of the ways in which you've sort of been a patient and family advisor and some of the things you've done.
Sure, absolutely. So one of the first things I got involved in is I mentioned that my husband ended up in the ICU, and then the ICU wanted to do some improvements, which I thought was interesting because I actually thought that was the best part of the hospital. So the fact that they wanted to improve to me was actually a good sign. And so I sat on a committee with doctors and nurses and support staff and the social worker. A whole bunch of people were on that committee, and we really were looking at. And my focus has always been about communication, how to improve communication, and partly the only thing when he was moved from ICU to the acute care side, it was kind of like a shock to me that he was moving. It sort of seemed like. And I get that there's a shortage of ICU beds, but nonetheless, it didn't seem like it was communicated very clearly. I will say that. So part of what they've done, and one example, for example, when my husband was in ICU, I went to go visit him and they said I couldn't go in. I mean, I'm the wife, right? And they said, well, we're doing something. I said, well, I'm the wife. There's nothing you can, I've seen him more than you naked, right? So whatever you're doing, I can see, right? And then when I actually went in, his granddaughter was there. So how can she be in there? She shouldn't be in there if I can't be in there, right? So there was definitely some communication glitches going on there. So part of one of the changes that family members can be in the room when they're doing treatment and so on. I mean, it's a choice, but it's not like before it was not a choice, right? So those are some of the things that I was able to kind of work on, working directly with a committee at the hospital to make positive change and to help. And they've also made some other things around communication and things which are actually, I know that's extended throughout the 3 hospital sites. Also working on, like, framing conversations and things about communication around all the things that are happening right now in terms of there's some new technology things happening in the system coming through and things like that. So, and those kind of processes. So we were able to at least listen. I'm not sure we gave much opinion on it, but we're able to listen to some of the things and share some of our concerns around that as well. So there's lots of opportunities where we've actually had a chance to make a small difference or a big difference depending on the process. So I sit on a couple of subcommittees, and I now sit on, well, actually it's a lot of committees now. They expand. Be careful, they expand. So
And so I'm going to actually try to share a video with you where we can sort of hear the stories and hear the voices of a few of our patient and family advisors. And what I really like about this video is that it's actually shared with every single new staff member that starts at SHN. And so the idea is that we're remembering sort of patient voice right from the beginning when you start with the organization. So let me see if I can get the technology to work. So hold on.
and that logo at the very end is the stamp of approval from the Patient Family Advisory Committee that we approve this message, basically, or whatever it is. So that's what we do at the end of something as well.
All right, let me see if I can get this presentation started again. Yes, all right. So we had a lot of examples of folks who had positive experiences, but as you could see with one of our values is that the Scarborough Health Network does encourage patients and their families to, take an active participation in their care. And so there's going to be moments where you have a concern about something that is happening with yourself or with your loved one. So who do you speak to when you have a concern? I think that's what I want to address now. Okay. So the first person you should speak to when you have a concern is you should bring it up with your healthcare team. That is what the hospital recommends, is that if your issue is if you're an inpatient or an outpatient, if something is going on, especially in the moment, in real time, please bring it up with your healthcare team or your attending physician. That is the place to start. That being said, if whoever it is that you spoke to that's part of the team does not address the concern to your satisfaction, your next step is to speak with the program manager of the unit or department. So you can call the hospital and ask for the name of the manager. On the unit, you can go to a nursing station and say, can someone please provide me with the name of the manager and a contact and a contact number or contact email for the manager. And you have a few different ways in which you can try to reach out to that person. So you can try to phone that person, you can email that person, or you can ask to meet them in person, right? Like whatever sort of works for you. Managers are expected to be somewhat accessible within their sort of what their schedules permit. Now you're at step 2. So say the manager does not address your concern to your satisfaction. The next step is actually to go and try to talk to our patient relations department. So the patient relations department is, how do I put it? There's a lot of different names for patient relations throughout sort of different hospitals in Ontario. Sometimes they're called the patient advocacy office. Sometimes they're called patient relations. Sometimes they're called patient experience. It sort of depends on the office. But here at the Scarborough Health Network, they're called the Patient Relations Hospital. And their information is all publicly available on the website, or if you reach out to, again, someone on the unit, or if you just call the hospital, you can get a contact for the patient relations person. And there's one person at every single site, and they are someone that you can talk to, and their role is sort of to elevate that patient voice throughout the hospital when needed. And as Jan and I were preparing for this presentation, we chatted a little bit about what Jan wished that she knew when she was interacting with the healthcare system and had to advocate on behalf of her husband. So I'm going to stop talking and let Jan share some of the things that she's learned that she wished she knew when she was supporting her husband.
So the first step is indeed to ask the person who's there. That's all, I mean, and you just kind of assume people do their jobs and you shouldn't have to check, but you do have to check, right? So, and it's, people are busy and it's crowded and all sorts of things are happening. And the squeaky wheel sometimes does get attention. So that's something you should pay attention to. But then dealing with like the manager is a very good advice. So when my husband went in with that time with pneumonia and he was in the isolation, and then they're moving him from that out because he doesn't have to be in that room anymore, and a ward. This happened actually twice, but in this particular time, he moved him into a ward instead of into semi-private. And it was a terrible place. And there was a very terrible patient in there who was being, I can't even describe how offensive he was being to the staff. And it was just a horrible, horrible place. And I'm paying for semi-private. So why are you putting me, or putting us in this ward? And the reason was that the nurse wanted to be closer to him. So I actually had a private conversation in the storage section of the hospital with the chief nurse, or whatever her title is, right? About, my concerns and the problems and things like that. So the very next time when they were doing a shift, he moved out into semi-private on the other side kind of stuff, right? So speaking up about your concerns is really, really effective. And you don't have to go all the way up to patient relations. Just have an honest conversation. Doesn't have to be in public with everybody listening. That's why we were in the storage room. But it was very effective, right? So that's a process. And like that there are people who want to help. So one time I was in the Margaret Birch side, and the elevator said that it had last been inspected in, I don't know, last century, and was always breaking down. So I thought, this is just really annoying me. So I went to find somebody to speak to about the elevators. And I just looked around. And because Margaret Birch is on the other, if you're not familiar, and if you want to go to Tim Hortons, you have to go across the big walkway to get to Tim Hortons, which is what I was doing. And then I saw a person, and I think it was patient relations, went, oh, look, but they weren't there. So I talked to this other guy, and I told him about the elevator. And he said, well, it's not his responsibility, but he knew whose job it was. And he would email them my concerns. So even though I had completely the wrong person who doesn't deal with elevators, he at least was able to address it and send it off to the person in charge of elevators. Because, you know, they're always breaking down, and I would like to just be able to arrive and go up to the floor that I was going to, right? So that's the kind of thing, like, it doesn't have to be the right person necessarily, just finding a person to voice your concern with also will be effective, right? And then once you kind of get to know things, you find ways in how to kind of navigate the system. So I think those are the two things I wish I'd known, that you had to advocate and that it doesn't always have to be the right person. As long as you find someone, and I took the card of the patient relations person, and then we became best friends because I spoke to her a lot after that.
So what does patient relations do? And I think a lot of folks, I think a lot of folks who aren't that familiar with the healthcare system, they wouldn't know that, oh, I have a comment or concern or complaint, I need to call patient relations. Like, that's not an instinctive department to look up or to Google when you're looking to see who you need to talk to. But just to kind of explain what that department does. So our patient relations office, if they receive a complaint, there are a number of steps that they will take to follow up on the issue and to help ensure that the issue is addressed. So they do respond to emails, phone calls within, from what I understand, 1 to 2 business days. And they also, some people do write them letters because that's what's most comfortable for them. And they do try to respond within 5 business days. If the complaint comes from someone other than the patient, they do work hard to ensure that they have consent from the patient to discuss what's going on. In situations involving individuals who are not able to consent, consent to release of information has to be obtained from the substitute decision maker or appropriate person. They have a whole process involved for that, but I just thought I would mention that. So they will investigate the case based on the information provided, and the investigation may include some or all of the following. So contacting a care provider, contacting managers or department chiefs or other supervisors, reviewing the patient's chart, or contacting other relevant departments, so finance, dietary, facilities, diagnostic imaging, etc. So for example, Jan was talking about, you know, the food not being correct. So that is a department that, if you've gone through the steps, could help you with that. And then once they've finished their investigation, patient relations will communicate the results of the investigation as soon as possible. That being said, not everything is a case. I think this is the language that department uses because that's sort of how they operate, but not everything is a big case and a big investigation. So I can give you an example of when I was at a different organization and I was working in an area, and patient relations called me because a patient's loved one was trying to get trying to get a patient television access. Because the patient was bored and just, you know, and they couldn't figure out who to go to, or it was a long weekend or something was happening. And so I was basically able to work with patient relations and help them figure out, yes, it's an external company that does the televisions. We have a tech on site. This is the person, this is their contact. This is when they come on site. This is the cost. This is how you pay. And they were able to relay that information back to the loved one. So it wasn't a case, it wasn't open for, you know, 3 or 4 days. No one had, it was something that they were just able to do, that they were able to facilitate. So that's an example of something that I think as a patient or a loved one might have taken you a really long time to do, but patient relations was able to quickly call, you know, me, and I was able to sort of sort that out. So that's kind of an example of what of small things patient relations do. And I don't really think I can talk about some of the bigger things because that's just sort of outside of my scope of expertise, but that's, yeah. Jan, did you want to add anything?
I mean, yeah, I mean, you can just, like, you can have little things and big things. That's exactly right. I mean, in the process for me was about the food was a big thing for my husband, getting it correct. seemed to be a challenge for a while, and the processes and things like that. But also in terms of when he went back into the hospital and I was going to spend the night, she was facilitating getting me a place to sleep in the room so that I wouldn't have to like scrunch in a chair that's not very comfortable, right? So I mean, it's big and little. This is not ongoing. This was just a kind of like a service, I guess it is, right, to kind of help. In the end, my husband passed before the bed arrived, actually, so it didn't matter. But I mean, the fact is, they were making that effort to actually make it happen. Was the kind of the thought that you could actually have in the process. So.
And a legitimate question that some people do have is, what if patient relations cannot resolve your issue? So I've put two areas that you could go to if patient relations is unable to resolve your issue. So one is the Ontario Patient Ombudsman. So they are not affiliated with the hospital. And essentially they are the body that you can escalate to if the hospital cannot resolve your complaint. So if after the investigation is complete and you are still not satisfied with the outcome, you can elevate your concerns to the Ontario Patient Ombudsman. They are, I believe their services are free and confidential. So that's somewhere that you could go. The other place that you could go is you could actually contact one of the regulatory bodies. So this is a possibility if your complaint is about a regulated health professional. So that could be a physician, a nurse, a physiotherapist. So they all have colleges that they belong to, and you could go and bring your concerns to that college as well. Ideally, no one has to go to these extreme lengths, but I just thought I would share them in case, in case this was of need or of interest. Jan, anything? Okay.
I have nothing to add to that. I have never had to go that far.
Okay, and I'm glad, and I am glad that your issues were able to be resolved in-house. Yes. And so other methods of providing feedback. So patients, we do have patient surveys that patients do fill out. So I do know from my own experience working in patient experience that patients and loved ones, like Jan said, aren't comfortable providing their feedback right in the moment, that's just not something that folks want to do, and that's absolutely fine. There are some opportunities to do patient surveys once folks are discharged, and so sometimes that is how the hospital does get feedback about things. And then obviously there's patient and family advisors, and depending on what level of change or you're looking to sort of influence, there's department level patient and family advisors. So for example, we have patient and family advisors that work with our adult mental health program. So that's a department specific group. Then there's also there's a corporate patient and family advisory group that sort of looks at things across the hospital. There's also patient and family advisors at the Ontario Health Team, which is sort of above the hospital. And then there's also patient and family advisors at the ministry level. So there's lots of opportunities to provide feedback, yes, at all different levels.
And just, you might not know, OHT is an Ontario Health Team, which is a new system that's just been introduced in the last year and a bit, I guess, right? So we're part of the Scarborough Ontario Health Team. And I sit on that committee as well as a patient family advisor. And that woman in the middle of that photo, Lori, she also sits on that Scarborough OHT, and she was in the video that you shared.
So just some additional resources for anyone who's interested in them. And questions? Any questions from the folks that have been listening today?